Hello and welcome everyone. Today we will be reviewing the papers which were published last week. This is the EIT guided, that is electrical impedance tomography guided PEEP titration for optimal PEEP in ARDS. This is a systematic review and meta-analysis. To assess the clinical utility of EIT guided PEEP titration in improving ventilation in ARDS patients. It was a systematic review and meta-analysis with time sequence analysis. Comprehensive screening of the electronic database up to 30th November 2023 was done. RCT controlled clinical trial and comparative cohorts which have assessed this versus conventional were used. 515 patients with 5 controlled cohorts and 2 RCTs were included. The key findings were that EIT guided PEEP titration reduced mortality 0.68, the relative risk reduction. Dynamic compliance was improved, which was 3.46. Oxygenation did not find any significant improvement. The required information size was achieved by mortality reduction and compliance improvement with power of 95%. And the EIT guided PEEP titration showed promise in reducing both mortality and improving the dynamic compliance. However, no significant improvement in oxygenation was observed. So the implication is that it can be used as a potential for benefit in ARDS patient, but more research is definitely needed to establish this as a treatment modality. The next is LOLOL for refractory VF in out-of-hospital cardiac arrest. This is a randomized double-blind placebo-controlled pilot. The objective was to test the efficacy of this drug, which is a beta-1 receptor selective blocker, in treating out-of-hospital VFs. It was a randomized double-blind placebo pre-hospital setting in Vienna, Austria. 36 patients aged 18 to 85 with out-of-hospital and refractory VF, which was defined as VF persisting after at least 3 defibrillation attempts. Patients were randomized to receive either landiolol 20 bolus or placebo. Time between trial drug infusion to sustained ROAC was measured. Secondary outcome was ROAC temporarily sustained, ROAC under eCPR, survival at 24 hours, and favorable neurological outcomes. Safety parameters like bradycardia, systole, PEA were observed within 15 minutes. Results, no significant difference in time to sustained ROAC. Secondary outcomes show that sustained ROAC was lower in landiolol, and ROAC within 30 minutes significantly lower with this group. Temporary ROAC significantly lower with this group, and survival at 24 hours was again lower. No significant difference in neurological outcome. In terms of safety, bradycardia was more, asystole was significantly more, and so the conclusion is that landiolol did not improve the outcome of the patients. So the implication is this pilot did not give much benefit from landiolol, so we may need more trials or better treatment protocols for patient selection. The next studies is IVC and lung ultrasound guided treatment of acute heart failure. So they evaluated the use of this strategy in guiding treatment of heart failure. It was an investigator-initiated single-center, single-blind RCT in Australia. 60 patients with acute heart failure. Patients were randomized to either this Caval ultrasound group or control group, which is standard care. Primary point was presence of more than 5 V lines or increase in IVC diameter and collapsibility at discharge. Secondary outcome were composite of the readmission to heart failure, unplanned visit, and death at 90 days. Key findings were that they achieved 4 patients, that is 13.3 patients in Caval group versus primary endpoint, and 20 patients in the 66% group. Secondary endpoint was significant reduction in heart failure, readmission, unplanned visits, and death. NT-proBNP reduction was not statistically different. Safety with the ultrasound strategy was seen. And in conclusion, we can say that there was a significant reduction in the subclinical congestion at discharge at acute heart failure when the treatment is guided by IVC and lung ultrasound parameters. The next is a study of vitamin K antagonist reversal for urgent surgery using 4-factor prothrombin complex concentrate. It included 118 men, 90 women, adults taking vitamin K antagonists who have urgent need for surgery and significant bleeding risk with a median age of 67.5. It was 27 hospitals in US and Europe. It was 105 investigational 4-factor FFP was given. Out of this, 208 participants were randomized. 103 received the control, that is 4-factor PCC only. And in the primary outcome, effective hemostasis as surgery end assessed by blind independent adjudicators using 4-point ordinal scale. A non-inferiority margin of 0.15 was used, and the investigation find that there is no inferiority of using this strategy. It was similar in the two groups. The next is prolonged versus short awake time in COVID-19 patients. The method used was RCT open label trial conducted in 12 hospitals in China, 409 non-intubated patients. They were randomly assigned to prolonged, which was more than 12 hours for 7 days, standard, which was shorter periods of 7 days, 205 and 204 patients in each group. Endotracheal intubation at day 28 of randomization was a primary. Mortality and adverse effects were noted. The duration of prone ventilation for prolonged was 12 to 14 IQR. Standard was 2 to 8 IQR. And the primary outcome was intubation. It was 17 in prolonged and 27 in standard. Relative risk reduction was 0.6. Hazard risk for intubation was 0.56. Secondary outcomes showed that hazard ratio for mortality is 0.63, and adverse incidents were lower and similar in both groups. Prolonged awake ventilation in COVID-19 patients reduces the rate of endotracheal intubation, but obviously we need more larger population to corroborate the findings. The next is a multicenter RCT comparing 3 times a day intermittent enteral postural feeding to continuous enteral feeding. And the methods used here was a multicenter RCT, 5 multidisciplinary ICUs, 120 mechanically ventilated patients. Intervention, as we have shown here, postural feeding with 3 times a day gastric feeding in right lateral tilt position versus continuous. Feeding protocol was standard practice for feeding formula, target daily feed volumes, and postural turns for all patients. Primary outcome was incidence rate of 100 days of gastrointestinal tolerance, composite vomiting, diarrhea, and constipation. Secondary outcome was mortality, GI intolerance, ventilator-free days, episodes of vomiting, and mean diet volume ratio. Results, 120 patients, median age 65, 60 male, 61 and 59 in the two groups. Primary outcomes, the incidence of GI tolerance did not differ significantly between the two groups. And the secondary outcomes, the GI tolerance until day 14 was similar in both groups. Number of episodes of vomiting did not differ significantly. All-cause hospital mortality in intermittent was 20 and 31 in the control, but it was not statistically significant. No other significant changes were seen. So in conclusion, intermittent feeding delivered was as good as continuous. The study suggests that intermittent feeding may be a feasible alternative to continuous feeding for mechanically ventilated patients. Thank you for your patience.